walking through how we developed the tool, considerations for how to use it, and then kind of walking through some data examples pulled out from the tool. So with that, I'm going to jump on in. So our team gets a lot of data requests, and historically always have. We get a lot of data requests from partners like you guys who want their decisions to be data-driven. They want to be able to make decisions that consider health equity. But historically, I think the data that was available for decision-making in the substance use space was overdose death data. But as I'm sure we are all aware, there's a lot of other factors that affect communities, in relation to substance use for individuals and at the community level. So our team wanted to create a more comprehensive tool that we could make available to our partners that kind of had a health equity approach and that was flexible for decision making. So that was kind of the impetus for us deciding to create the MySUBI. So just kind of a brief overview of our process. We decided to create a vulnerability index. It's in the name, but that's kind of like a popular thing to create right now in the data realm. So we did a lot of background research and looked into how other areas were creating tools like this before we created a proposed methodology. We brainstormed different indicators that like data points that we thought would be relevant. And then we took our proposal to our stakeholders. And many of you were probably on those meetings where we asked people's feedback. We asked, what they thought about the methodology and for more input onto the data that we should include in the indicator list. Once we had this massive list of indicators, we tested them and decided on the final list, and then we created the score and disseminated it. So I am going to jump in now to the methodology. I'll try not to get too far into the statistical weeds. Sometimes it's a little hard not to as an epidemiologist, but I'll try to keep it high level. So essentially the MySUBI functions as a composite index score, which is just a single score that takes multiple different indicators and standardizes them and then adds them together. So you get the single final composite score that is affected by different data indicators that aren't always initially on the same scale. So at the beginning of this project, we decided we wanted to think about kind of these three larger buckets that affect a community's and individuals' vulnerability to substance use. And so those three buckets to us were equally important, and those are substance use burden, substance use resources, and then the social vulnerability or kind of social infrastructure of communities. So within each of those buckets, we have different specific data points that feed into the bucket in a standardized manner, but each of these three things is equally important in the MySUBI. So I'm not going to go through all of this, but just to give an overview of kind of all of these different data indicators that stakeholders told us they felt were relevant and that we were able to get kind of standardized data points for. These are all of the data points that we considered for inclusion. And they're color-coded based on the bucket of the SUBI that they fell into. So this is everything that we ended up testing. And so when we were considering which of these to include, we kind of had a list of different data characteristics that we would look at for each indicator. We looked at the data quality, the strengths versus the limitation of the indicator, what the value add would be. We looked at correlation between different indicators so that we weren't including duplicative indicators. And then we kind of got subject matter expertise opinions before we winnowed it down into our final list. And so of those 30 or 40 indicators, this is the final model of what goes into the SUBI. So within that burden bucket, we have the 5-year average overdose death rate, the 3-year average non-fatal overdose ED visit rate, the drug-related arrest rate, and the opioid prescription rate. And I should say that we built this score initially at the county level. So we were looking at these data points at the county level. Within the resources bucket, we looked at treatment and SSP access. And the way that we looked at that at the county level is we looked at what percent of the population was within a 30-minute drive to an SUD treatment center, and then what percent of the population were within a 15-minute drive to an SSP. So how accessible is SUD treatment and harm reduction services in terms of drivability? And then we also looked within the resource bucket at the buprenorphine prescribing rate. Finally, for the social vulnerability bucket, we kind of built off of an existing tool that was published by the CDC, and that was the social vulnerability index. So I'm going to jump into that on the next slide, but these are the data points that feed into the MySUVI. So there are 8 different data points feeding into it in these 3 buckets or components. If you are not familiar with the Social Vulnerability Index, it is a tool put out by the CDC. It's another kind of composite index score, and it looks at community level social characteristics to assign a score of how a community might be able to respond to adverse events. So it could be like an environmental disaster or infectious disease or substance use. So looking at those factors that we know to be social determinants of health and that are incredibly important to consider in terms of like health inequities in communities. So this is kind of the structure of how the Social Vulnerability Index works. There are data points that look at socioeconomic status, housing composition and disability, minority status and language ability of residents within a community, and then housing type and transportation access. And so those are all data points that come from the American Community Survey. We actually ended up modifying it slightly and adding one additional kind of data component called healthcare connectedness that we thought was incredibly important when thinking about substance use disorder and substance use vulnerability in communities. And so that healthcare connectedness pillar had 4 additional data points looking at the percent of households with access to a computer, smartphone, and internet. So thinking about like virtual care and connecting with peers, we thought that point was important. The percent of the population without health insurance. And then we looked at similar access measures with healthcare. So the percent of population within a 30-minute drive of an acute care hospital, and then the percent of population within a 15-minute drive of a pharmacy. So that is kind of the background I wanted to give on how and why we created the SUVI. I'm going to jump in right now and kind of do a live demo. We house the SUVI data on our Michigan Overdose Data to Action dashboard that I just pulled up. And so I can share that, that link in the chat later, but this is a publicly available data dashboard. If you haven't gotten a chance to check it out, I definitely recommend it. There's a lot of really interesting data on it. We have non-fatal overdose, fatal overdose, SUD treatment, syringe service program data. There's kind of a wealth of information on here. And we have our substance use vulnerability index data on here as well. So I'm just going to quickly walk through the pages and the data that are available on here. So within the vulnerability index page, there are 3 subpages. On the first page, it just gives an overview of the MySUVI, how it works, similar to what we just walked through. And then there is a map that just overviews the scores at the county and the zip code level. So right now we're looking at the composite MySUVI score, but you can toggle through and look at the burden, resource, and social vulnerability scores. And you can also we have recently published this data at the zip code level. So you can toggle between that on the map. And again, you can look at the different components of the score. You can also select a county to highlight, which I think is a very cool feature, so that the zip codes associated with that county kind of pop up and you can see how it looks. And see the colors of that county in relation to the rest of the zip codes in the state. So that is the homepage. On the second page, we have the county scorecard. I'm going to scroll down and click a different county, but this page is only available at the county level, not the zip code level, but this page is kind of the scorecard. It overviews at the county level, like how that county is doing in terms of the SUVI and the components of the SUVI. So over here, it's kind of like a report card. What's their rank? What does that mean? Are they better or worse than the Michigan average? Down here, we have a bar graph where you can see your county, highlight the county you've selected, highlighted in red compared to all other counties in the state. And you can toggle through any data point that feeds into the SUVI. So here I'm just pulling up the fatal overdose rate. And it's feeling slow today, it's thinking. Okay, so here we see, Calhoun is quite high in burden, and we see that reflected the fatal overdose rate. They're higher to the worst outcome end of the bar graph rather than the best outcome end in terms of fatal overdoses. I want to point out that all of our graphics on the dashboard, you can hover over them and then you can see a little additional data insight when you're hovering over. Up here in the top right corner of this page, we also have kind of a snapshot of the SUD resources that are available in the county. So the map highlights the location of syringe service programs, publicly funded SUD treatment sites that are registered with SAMHSA, and then pharmacies that participate in the naloxone standing order. So you can look in your county, see where those resources are. If you hover over the dot, you can get the name as well as the address of that resource. And then over here, you can kind of see a list of some of those resources along with quick response teams and drug courts. And you can toggle down and see a summary of what's going on in your county. This final page, the compared data points page, I love this page. I think it's really great for data nerds, but anybody can use it. So this page compares two different data points on a map. So it uses a technique called bivariate mapping. So it uses diverging color schemes so you can compare two different points and see how they intersect. So the points that I like to pull up when I'm demoing are the fatal overdose rate compared to SSP access in the state. So this grid down here kind of shows you how to interpret the colors. So the counties that are white, they have some of the lowest fatal overdose rates in the state, and they also have some of the highest SSP access. So in terms of these two indicators, those counties would be considered to be doing pretty well. And then the black counties are those that have some of the highest fatal overdose rates in the state and some of the lowest syringe service program access. So we would say those counties are kind of areas where resources may be needed, or we could consider scaling up certain interventions or harm reduction services there. So I think this map is just a really cool way to look at the intersection of points to see where there might be extreme vulnerability in our state and opportunities for interventions. And again, you can look at this map at the zip code level as well and choose a county that you want to highlight. The other thing that I want to highlight on our data page is we do have underneath the dashboard these public use data sets available. And so these are just Excel documents if you want to be able to dig into the data a bit more yourself. We're kind of in the process of publishing more of them, but these are the ones that are available. And we do have the county level substance use vulnerability index results along with the zip code level results. So I'm just going to pull this up quickly to show what it looks like. But yeah, if you want to dive in and get some of the more specific data or play around with it yourself, this is where you would want to head to. So each of these workbooks has the specific indicators that go into the SUVI. So you could look either by county in that worksheet, or here we're looking at zip code, exactly what the data indicators are. What is the fatal overdose rate? What's the opioid prescribing unit? And then you can look at different standardizations of the scores. And then we also do include an extra sheet with all of the variables that go into the social vulnerability index. So you can, I think these are really interesting to look at. You can see like the percent of individuals in that county or zip code that are below the poverty estimate or that are unemployed. So there's just a lot of data available in the SVI as well that can be really useful to pair alongside with SUVI results. All right, I'm going to pull back up my presentation and kind of just talk about now some recommendations for how to think about the SUVI, how to use it, and then walk through some specific data examples that our team has pulled out of the SUVI data. So just kind of some use cases that we've identified the SUVI can be useful for, or we've heard from our partners that it's useful for. I think it can be really useful for grant writing, especially with all the different data components. There's a lot of pieces that you can pull out for your community. So alongside that with funding allocation, and then identifying communities of focus where we can scale up interventions. But one thing we really want to make sure our partners are considering when they look at the SUVI, and just anyone who's looking at the score, like the My SUVI score is not the end all be all score. It doesn't have it shouldn't have the absolute final say when you're thinking about substance use in a community. There's a lot of nuance in communities that should be considered when you're making decisions and tailoring programs. So we really encourage people to use the SUVI alongside health inequities data and local knowledge of what's going on to really consider the full picture and to not just consider the My SUVI score in a silo. So now I'm kind of going to jump into some ways you can analyze data, some examples to get kind of the wheels turning in your brains. So this first slide is looking at Eaton versus Monroe County. As I mentioned at the beginning of the presentation, historically, we've often just looked at drug overdose deaths, the drug overdose death rate when making decisions about funding and program allocation. So Eaton and Monroe actually have approximately the same drug overdose death rate. But this page is kind of highlighting just some differences between the two counties that would be important to consider when you're considering implementing programs there, ways that they differ that you wouldn't be able to determine just looking at the drug overdose death rate. And so this data is pulled out of that county scorecard page. So we see that Eaton County actually has a slightly worse My SUVI rank. Their burden scores are pretty comparable, but we see that Monroe County is significantly better resourced than Eaton County is, while their social vulnerability scores are approximately the same. And when we look at the resource list, we see that Eaton County, they do have an SSP, they have SUD treatment and a pharmacy participating in the naloxone standing order, as well as quick response teams, but they don't have drug courts. Eaton County does have drug courts, but they don't have a syringe service program and quick response teams. So I think those are just kind of some important things to think about as we think about interventions there. Eaton County might not have as much access to harm reduction services as Monroe County does. This next slide is pulling out some of that social vulnerability index data. So that data that kind of looks at the social characteristics of communities that are known social determinants of health and that really affect how individuals are able to maintain healthy lives or to access treatment or medical care.
Alexa, stop music.
So just going through some of these key indicators we pulled out, comparing the two counties, we see that Monroe County actually has a greater proportion of individuals who are living below the poverty estimate and more individuals with no high school diploma. But Eaton County has more individuals who are not white, non-Hispanic. And then we see some housing structure differences as well. So again, these things are really important to consider as you're thinking about your patient population or the programs that would be serving these communities. Thinking about, if a person is living in poverty, it may be extremely difficult for them to go to a residential treatment program if they don't have clothes they can change into. So I think we don't always think about those those social characteristics as much when we're program planning, but they are incredibly important, especially as we think about addressing health inequity. Another example that we just pulled out of the SUVI scorecard page, Crawford County is pretty vulnerable in terms of its MySUVI composite rank. And what really stands out about Crawford, it has the highest drug arrest rate in the state at the county level. And we see that they actually don't have any drug courts that divert people into treatment. And so this is just kind of an example of maybe that's a place where there can be some ongoing engagement with law enforcement and more collaboration in that area. So again, just another kind of data intersection that the SUVI can highlight. And then we pulled out some data for Lake County here because they're one of the most socially vulnerable counties in the state. And so this slide here is comparing Lake County's social vulnerability characteristics as compared to the Michigan average. And so we see Lake County has more people living in poverty and with high housing cost burden than the state average, along with lower access to pharmacies and hospitals. So again, these are all really important to think about as we think about engaging the population of individuals with substance use disorder. And then this slide again, just pointing out how you could use the bivariate mapping page to compare data points. The left is we already kind of looked at in the dashboard, but the fatal overdose rate compared to SSP access. And then the right is looking at the non-fatal overdose ED visit rate in relation to the buprenorphine prescription rate. So kind of highlighting areas where people are surviving overdoses at high rates, but there is not as much medication for opioid use disorder being prescribed in that county. And then I know when I was talking with Tam about this beforehand, there was some interest in Oscoda County as it's the #1 county in the state. So I pulled out a few slides, a few data points on Oscoda County to just kind of highlight why they are the #1 state in terms of the MySUVI rank and just kind of how to think about the data. Because again, we don't want like the MySUVI rank to be the end all be all score. I think there's just more nuance to consider, and we should consider a lot of the underlying data and community characteristics as we look at this. So we see Oscoda ranks pretty highly in burden and pretty low in terms of substance use resources. And they're also have pretty high social vulnerability. They're the second highest socially vulnerable in terms of the SVI. And we see they don't have any, I think it's 0% of their population lives within a 15-minute drive of an SSP. And at least at the time of publishing this, there were not any SSPs operational within the county, and there are not any drug courts in the county as well. For this slide, I just kind of drilled down more into the zip codes in Oscoda County by highlighting on that first page the county zip codes and then pulling each of the different component scores out. So we can see that most of the zip codes in Oscoda County in terms of the total MySUVI score are pretty dark. So they would be considered more vulnerable than the average zip code in Michigan. When we look at the burden score, we kind of see the bottom left or the bottom zip codes seem to have higher substance use burden. When we look at the resource scores, we see actually the top zip codes seem to be less resourced. So the resources seem to be more concentrated in these southern zip codes. And then when we look at social vulnerability, again, most of the zip codes in Oscoda are pretty dark and would be considered very socially vulnerable. And then this page just kind of pulled out some data points from the county profile, looking at that bar graph. How does Oscoda compare to other counties in the state? At the top, we're looking at treatment access and SSP access. So as I mentioned before, none of the population of residents in the Oscoda County live within a 15-minute drive of an SSP. And And they are kind of low in SUD treatment access, but it still looks like approximately 80 to 90% are within a 30-minute drive of an SUD treatment center. We see they have a pretty high drug arrest rate, opioid prescribing rate, and again, are high in social vulnerability. And then this slide, again, just highlighting some of the social characteristics, because they're one of the highest socially vulnerable counties in our state. So comparing to the state average, we see a higher percent of individuals who are unemployed with no high school diploma, without health insurance, a more elderly population and population with disabilities, some housing indicators that seem worse than the Michigan average, and then they have significantly fewer households without a computer with broadband internet, double what the state average would be, which I think is really interesting to think about. And then they have a pretty low population, percent of the population that is within a reasonable drive of a pharmacy or a hospital. So again, I think these things are incredibly important to think about as we think about engaging the patient population in that state or rolling out interventions and programs in that area. How can we better engage with individuals with substance use disorder in this county while also considering the social characteristics of the county and hardships that the individual may face that prevent them from getting healthy? And then finally, this is just comparing some data points in Escoda County. So on the left, looking at the fatal overdose rate as compared to the social vulnerability index, we see, some zip codes in the middle bottom that are lighting up black. So that suggests that residents of that area are highly socially vulnerable and that more fatal overdoses are happening there. The middle graph is looking at the opioid prescribing rate compared to the buprenorphine prescription rate. So we see this zip code in the middle is lighting up black. So they have a pretty high opioid prescribing rate, but they have a pretty low buprenorphine prescribing rate. And then finally, this graph on the right is looking at the non-fatal overdose ED visit rate as compared to how accessible SUD treatment is in terms of drivability. So again, we see these black counties black zip codes at the bottom that have a higher than average non-fatal overdose ED visit rate and have low accessibility to SUD treatment.
Gabrielle, there's a question in the chat if I could.
Yeah,
the graphs that you've been showing about Oscoda County, are those generated by the SUVI program or was that something you put together?
Yeah, those are publicly accessible on the dashboard. So anything, the only graphs that you would not be able to generate like on the dashboard are those with the social vulnerability indicators. So like housing burden, poverty, but those are available in the Excel documents that you can download. So all of it is available online in various formats publicly. All right, I think this is my last slide. So just going back to the recommendations for use and even thinking about with Escoda County, like it's just incredibly important to consider local knowledge and even just like the breakdown of demographics within a community and known health inequities as we're thinking about how to better engage that population and tailor interventions there. So if you take one thing away from this presentation, don't use the MySUVI in a silo, pair it with other relevant knowledge as you tailor your programs and meet with patients. So that's the end. I'll say we're working on a few updates to things. We just recently rolled out the zip code data. We're hoping to put together some training videos this summer where we would be uploading this kind of information in this presentation onto the website. So it would be publicly available as you're using this SUVI. And then we're trying to make the Excel documents a little bit more accessible and less overwhelming because I know there's a lot of data in them. So keep an eye out. There will be updates that come out. And I think by the end of this year, we'll start updating to the 2022 score. And I am happy to take questions or go through anything.
Thank you for that. Does anybody have any questions? Please feel free to unmute yourself and ask away. If you're more comfortable posing the questions in the chat, feel free to do so as well. John, looks like you have a question.
Yes, will we get a follow-up email with all this information as far as the how to log in and all that good stuff?
We will, your local behavioral health consultant from Michigan Opioid Collaborative will follow up with everyone here in the coming days with some additional information. Gabrielle, are you comfortable with us sending out the slides that you presented today?
Yeah, absolutely. And I will drop the link to the dashboard in the chat as well. So that is where you can find the dashboard, and underneath the dashboard, the Excel documents.
We'll include the slides and the link and the follow-up email as well to everybody who's here today. There's a question in the chat that says, how often will the data be updated?
Yeah, so right now it is 2020 data. The resources, like on that map, were updated, I think in late 2021. We plan to update to 2022 data at the end of this year. We have a few data sources that take about a year to finalize. So we will be in the process of updating data soon. We do have a lot of other data on our dashboard, as I mentioned before, like fatal and non-fatal overdose rates and trends over time. And those are updated on a very timely basis. Some of our indicators are updated quarterly or monthly. So you can just be like checking and you'll see data updates as they come through. And it is the most timely data on substance use and overdose data that's available online.
Do we have any other questions?
Hi, I do. I'm Jeff from CMH here in St. Clair County. I was distracted and missed where you actually pulled up the Excel data for that information from the charts there.
Yeah, I can totally pull that up again. So this is the link that I posted. It should take you to this website. You'll see the dashboard up here, and then underneath the dashboard, there's a section called public use data sets. So there is a zip code file and a county file where you can download those Excel documents of the substance use vulnerability index results.
Perfect, thank you.
There's a question in the chat about some of the earlier slides indicated that some of the counties had data that was suppressed. And the question is, do you know why some of the data would be suppressed?
Yeah, I'm gonna scroll back real quickly. Hopefully this isn't too annoying. I'm guessing you're referring to this first page, that this is a map of the overdose death rate per 100,000, and that was in 2020. So our unit and the department's policy is when a county or a group has between 1 to 5 health events, so in this case overdose deaths, we suppress the count and the rate. We suppress the count to protect privacy, and then we suppress the rate for statistical stability. So again, I think that's another kind of challenge of working with just straight overdose death rate data. You see a lot of suppression, whereas in the SUVI, we used a 5-year average rate to kind of stabilize the rates to be able to include every county and zip code of the state.
You may have
anything suppressed in the SUVI.
I'm sorry, and you may have said this and it's actually what I was just going to ask, I think coincides with the question that's being posed here in the chat. The overdose deaths that are mentioned here, is it based on where they resided, where the incident occurred, or where they were pronounced dead?
So this map here is based on where they reside. And if people are interested in looking at like the specific numbers between overdose deaths and the overdose death rate, that data is available online. I can send out some different data resources that kind of walk through more of that data.
There's a question in the chat that says, is this data taken from the ERs and is anything taken from SSPs?
Yeah, that's a great question. So the MySUVI takes, it has 8 different data points. And so I have flipped forward again. I hope I'm not like giving you guys whiplash flipping through these slides, but the burden category looks at death data from death certificates, and then non-fatal overdose data from the ED, along with arrest rates and opioid prescribing rates. But then our resources do take into account the percent of the population that is within a 15-minute drive of an SSP. So we do have some SSP data in there as well, along with some other indicators you can see on this slide. I see, Pam, you commented that agencies like Harm Reduction Michigan are not counted in the data because you're not funded by the regional entity. Yeah, I think that's an important point. Is Harm Reduction Michigan, is that like an SSP or a different kind of organization?
We're really an organization that provides a lot of drug user health services, and doesn't just have to be drug user health, it's addiction related, addiction and its comorbidities. So it can be alcohol and could be video gaming addiction for that matter. But we operate in a number of counties, and so we're not in one particular county. So we do report to the syringe utilization program, but so I would imagine if you pull data, and I apologize that I signed in so late, so but if you're pulling any data from that, any of the overdoses we've reported into that system would be captured. But
Gotcha. Yeah, we do not have any data from the syringe utilization or the SSP utilization platform. I think it's what it is, the SEP,
yeah, I think
where
that's
you
what
would
the
be
piece
reporting that data. We don't have that within the SUVI. We actually are working to get more of that data onto our dashboard. So I think we're hoping by the fall we will have more data from that on the dashboard. But I think you make a really important point that like your efforts may not be reflected in the SUVI. And again, I just want to go back and emphasize like there is so much local knowledge that is incredibly important to consider when you're like program planning. The SUVI can't take into consideration everything. And, I think another big limitation is that at the state level, we actually don't have access to methadone clinic data. And so I know that is like a big hole in the SUVI as well. So that is definitely a recommendation of ours, is like to pair this alongside local knowledge of other programs that may be working in the area, or and just really being aware of the limitations and gaps of it as you're using it in your planning or thinking about it.
Does anyone have any other questions? Again, if you have any questions, please feel free to unmute yourself, or if you're more comfortable, please feel free to pose your question in the chat. Okay, well, if there are no other questions, we can end early and give everybody back a few moments of their day. I'll be here for a few more minutes if anything else comes up. But otherwise, thank you all for being here today. We hope we see you at our next event. Your local behavioral health consultant will be following up with you in the coming days, and we'll send you the slides from today, the link to the SUVI site, as well as some additional information. Again, I hope you all have a great day, and we hope to see you soon. Thanks, everybody.
Thank you.